Welcome, everybody. My name is Kelly Klein, pronouns she, her, and I am the clinical coordinator at the National Healthcare for the Homeless Council and your staff moderator. Today, we're going to learn about foundational terminology and concepts related to LGBTQIA+ identity in healthcare with a focus on experiences of homelessness. We do acknowledge that this is a vast and nuanced area of knowledge and practice that no webinar can fully encapsulate. But with that in mind, we are hoping for this webinar to serve as an evergreen 101 resource for staff at health centers and other organizations. So we will be recording the session and posting it on our website so that you can return to it if needed or incorporate it into ongoing staff trainings or onboarding, etc. Next slide, Sean. Before we dive into the content, though, we would love to get a sense of who all is in the virtual room with us today. So if you feel comfortable, I see some folks have already started joining in. Please introduce yourself in the chat with your name, location, organization if applicable, and pronouns if you would like. While y'all are doing that, I would also like to take this time to acknowledge that this presentation is supported by an award from HRSA, but does not necessarily represent the official view of HRSA, HHS, or the US government. I'm loving seeing the introductions roll in. Please keep them coming even as we move on to other slides. It's always nice to see some familiar names and also some new names. Welcome everyone, and we encourage y'all to be active in the chat throughout too. If you are watching the recording of this session at a later time, we also welcome you and are glad to have you here. Next slide. To lead us in our topic for today, I'm so excited to introduce our presenter, Sean Riley. Sean is the program coordinator of the Trans Buddy program at the Vanderbilt Program for LGBTQ Health, the first transgender patient navigation service in the country. In this position, Riley works with Vanderbilt's Gender Clinic, the only clinic for transgender health in the US Southeast. And with that, I'll pass it over to you, Sean.
Thanks so much, Kelly. Good day, everybody. Happy Friday. I'm so excited to be with you all to talk about this really important topic. Again, talking about healthcare for lesbian, gay, bisexual, trans, queer, intersex, and asexual folks, with a focus on folks experiencing homelessness and folks' experiences with healthcare. So we will go through today by first defining some common gender and sexuality terminology, including gender identity, gender expression, the gender binary, sex assigned at birth and legal sex, as well as sexual orientation and romantic orientation. We will then talk about health and homelessness disparity trends, including reasons and factors that make it so that these disparity trends exist, specifically for LGBTQ folks, and then summarize best practice guidelines for assessment and treatment of LGBTQIA patients. So as Kelly had shared earlier, this is a huge topic. And sometimes it feels kind of criminal to try and do it in as short of a time as even an hour and a half. And so some of these things, there may be other conceptualizations for things, there may be other experiences with various terminology. And I encourage y'all to use the chat to also to share your experiences if there's something that doesn't align or you might have experienced something different. But with that, I would love to encourage you all to take a moment and reflect. Have you ever had gender or sexuality concerns come up with patients, friends, or family that were difficult to navigate? So think about that for just a moment and use that situation as an anchor point as we go through today. And I'll ask you a second question. If folks were to stop you and ask, how would you define these terms, sex, sexual orientation, gender, and gender expression? How might you differentiate between these? What might be common between these? What do these terms mean to you? Now, I'm going to give you the best conceptualizations that we have at the Vanderbilt Program for LGBTQ Health, in acknowledgement that so much of our language changes all the time, and this is something that we have to try and keep up with as language and culture changes. The best language that we can use to support folks also changes. But these are our best conceptualizations of these identities and terminologies at this moment. So we'll start at sex assigned at birth. So a sex assigned at birth is a medically assigned identity at birth based on physical characteristics, largely our genitalia. So when a baby is born, and sometimes before they're even born, right, with sonograms, folks are gendered based on their genitalia. So if a baby comes out, and doctors or nurses see a vagina, they're often labeled female and go about their lives. Oftentimes those folks who are assigned female at birth grow up. Once they're in adolescence, we see that they usually develop the ability to create estrogen and progesterone at higher levels. And we also see secondary sex characteristics, right, like breast development. For folks that are assigned male at birth, those folks that maybe have things like a penis or testes, they grow up and at adolescence, of course, are able to develop higher levels of testosterone in relation to estrogen or progesterone, and have the secondary sex characteristics that are tied to that male assigned at birth. Now, even this binary of female and male is incomplete. We have to talk about intersex folks. So intersex folks, a outdated term and no longer correct term for intersex is hermaphrodite. You may be more familiar with this term. Historically, it's been understood to be some kind of ambiguous genitalia. So either folks are born with both a vagina and a penis, or some other type of just ambiguous or multidimensional genitalia. However, intersex folks and folks who have differences in sex development include a whole host of conditions that include differences in hormones as well as differences in chromosomes. So folks who have sex-linked chromosomal conditions like Klinefelter syndrome is actually technically an intersex condition, or folks who are able to produce both high levels of estrogen and testosterone, those folks would also be considered intersex. Oftentimes those things, hormonal differences and chromosomal differences, aren't able to be noted until later on, which is why they may be assigned intersex later on in their lives versus at birth. But intersex folks actually comprise of almost 2% of our population, 1 to 2% of our population. That is just as likely in this world as being born with red hair. Incredibly likely. So please don't misunderstand. I'm not in any way saying that all redheads are intersex or all intersex folks have red hair, but it's just as likely in this world to be born with red hair as it is to be born with some difference in sex development. So this is our sex assigned at birth, which is different oftentimes, but is also the same most times as legal sex. So our legal sex is a legally assigned identity, largely based on one's sex assigned at birth. So if I was born, the doctor says I'm female, they put it on my birth chart, they put it on my birth certificate. I then go and get a license when I'm older, that'll have that same female on it. If I want to get a passport, it will have that same female on it, although now people are able to add X on their passport. So this is our legal sex. Now I differentiate between legal sex and sex assigned at birth because for many people, folks' legal sex may not actually align with their sex assigned at birth, particularly for trans folks. So for example, if I was assigned female at birth and I grow up and identify as a man, I may change my legal sex to actually be male or man. Therefore, my legal sex doesn't always align with my sex assigned at birth, but they're both important for different reasons. Obviously, with our sex assigned at birth, that can give us some clues into things like healthcare treatment, but our legal sex as well, it is definitely clues us into or helps us connect to other systems, right? So again, legal sex is something that can be changed in a lot of places. In the United States, Tennessee is the only state where you're not able to change your sex on your birth certificate. Every other state actually in the country you are able to. I do like to add kind of the caveat that although that is true that in every other state there is some kind of pathway in order to get your legal sex changed, oftentimes there are really kind of draconian barriers to allow folks to change their documentation. So some states require that folks have some kind of gender affirming surgery and have to prove it to the courts in order for them to get their birth name or their birth gender changed. There are other places like Alaska, the rule is still on the books that says that if you're going to change your name or your sex, you need to put it in a newspaper for 6 weeks leading up to the court case, which of course, is an incredible barrier for trans folks, and makes it very dangerous, right, when there's this very public announcement. Of course, these things are enforced at different levels in different places. Some of the things are on the books and may not be enforced in every county of a state, but a lot of the abilities and pathways to actually change your legal sex are dependent on things like surgeries or surgical intervention. So our sex assigned at birth and our legal sex is often different for trans folks than their gender identity, right? And so our gender identity is our cognitive sense of who we are, right? It's how the heart and the mind perceive the body. So while I may be assigned female at birth as my biological sex, or even if I look at my license, there's a female on there for my legal sex. For me, my gender identity is actually non-binary, right? So that's my gender identity. It's how I cognitively see myself, regardless of what my sex was assigned at birth and what my documentation may say, right? So if we look at the list of words on the bottom, I'll start with the left. Cisgender woman. So cisgender woman, meaning that your sex assigned at birth aligns with your gender identity. So if I was assigned female at birth, I grew up and identify as a woman, then I'm a cisgender woman. Similarly, if I was assigned male at birth and I grow up and identify as a man, then I'm a cisgender man, right? Cisgender meaning same, where transgender means there's a difference between our sex assigned at birth and our gender identity. So for trans women, folks are assigned male at birth, grow up and identify as a woman, they are a trans woman or a transgender woman. Whereas a trans man was assigned female at birth, grows up and identifies as a man, transgender man. Now there's this whole other category of identities that is non-binary, which I named as the identity that I identify with. And so to clarify this a little bit more, I'm going to move to this next slide. So all people fall into one of two primary gender categories. Cisgender, so again, that sameness is what we see here to the left, where sex assigned at birth aligns with one's gender identity. Whereas transgender folks, their sex assigned at birth does not align with their gender identity. Now within the trans community, we have binary folks. So that means folks who identify within the binary of man or woman, right? So transgender men or transgender women are those folks that do identify as trans, so their gender identity doesn't align with their sex assigned at birth, but they do also identify within that binary. On the right outside, we see non-binary. So non-binary folks are folks whose sex assigned at birth does not align with their gender identity, but they don't identify fully within this gender binary of man or woman. So for example, folks may identify as gender fluid. So maybe they move between genders. Folks may identify with two or more genders. So folks might identify as being both a man and a woman, which might also be called bigender. Folks might not identify with any of the genders, and that is called agender or agenderism. And genderqueer folks as well. That's another term that I like to use for my identity. And for me, it means queering that box of gender. There isn't really a box that really fits for me. And so it's kind of this squiggly line circle around that box, right? All of these identities have different understandings for different people. But that's not unlike cisgender folks, right? If I were to ask 100 women what it meant to be woman, cis or trans, I'm going to get 110 different answers, right? And the same thing happens for non-binary folks and binary trans folks. There's different ways that people understand their gender identity, their gender expression, and all of them are valid. Now, sometimes I can get comments or pushback that there's a lot of these identities, like how am I supposed to keep up with all of this? And believe you me, I work in a trans health clinic. And particularly when I'm working with my young people, I hear new identities all the time. And it can be really intimidating to try and keep up with. My best suggestion to you is to do your best to keep up with the language as much as possible. But we can affirm people without expertise, right? We don't necessarily need to know every single thing about somebody's identity and how they feel for us to just appreciate and respect them in the ways that they want to be respected, right? Oftentimes people will also say, well, like, how can we have all these different conceptualizations of people in the world? Like there's two genders, which again, if we look at biological sex, even that two gender biological determinist idea, right, that there's male and female is broken up by this idea of intersex, right? Something that I like to think about is the fact that we can break up people in the world into like 180 different countries, and there's not a question about it, right? Like we have this understanding that like, if you're from this place, like this is how you identify. I don't need to know what it's like to be Bolivian to know when somebody says I'm called Bolivian, that I can just respect that, right? I don't need to know every single thing about somebody's identity in order to respect that identity. So again, the best that we can do is mirror language that folks give to us, and just respect folks as they ask to be respected. So our gender identity, that's our cognitive understanding of who we are, is different than our gender expression. And our gender expression is how we communicate our identity to others, right? So through mannerisms, clothing, body language, hairstyles, all sorts of things, interests. And if we take a second, we can think about things that in this society today, we would label as feminine. So often things like dresses, purple and pink, jewelry, makeup, horseback riding, for example, masculine folks, or folks that are expressing themselves masculinely, we may associate with sports and basketball shorts and the color blue and trucks, right? We're androgynous, meaning gender neutral, right? So this might be a mix of two different things. This may be just something that kind of evades all kind of labels of feminine or masculine. Now, the thing I like to point out about gender expression is this changes over time and it changes over space, right? What is considered feminine or masculine here in the United States at this point, or even within different regions of the United States, would be considered a different gender expression somewhere else. So if we were to look at, for example, parenting books from the early 20th century, a lot of parenting books would actually tell parents to dress their little boys in pink because it was seen as a manly color because it was a derivative of red, right? And red was the color of blood and war and royalty. And so pink was seen as a derivative of that, and therefore little boys should be dressed in pink. That has obviously flipped in the last 100 years. I think you would be hard pressed to make a case that pink is seen as a masculine color today. But it just kind of shows like the ways in which our gender expression and the ideas of gender expression change over time. Another way to think about this is if I have a young person today, that a female that comes into my classroom that uses pants, it'd be hard pressed again to say that that is something that's largely masculine. But 60 years ago, 100 years ago, if a woman was wearing pants, that's all of a sudden seen as a very masculine thing and altogether inappropriate. However, if that same female student comes to prom later that night and is wearing pants, all of a sudden she is seen as masculine, right? So it depends on our culture, it depends on our experiences, it depends on the setting, and it's all very socially constructed. That's what I would like to point to. This is all very mediated by time and space and culture. Now we have our legal sex, our sex assigned at birth, right? We have our gender identity, which is our cognitive understanding of ourselves. We have gender expression, how we might communicate ourselves to other people. And then we have orientation, sexual and romantic orientation. So this is the ways in which we orient ourselves to the world through sensual, romantic, emotional, affectional, relational attraction to other people. Now I break up sexual and romantic orientation because more and more we're developing an understanding that for some people, sexual and romantic orientation don't always perfectly align. So I will go through some of these words that we see on the bottom that are some of our more common sexual and romantic orientations today. So lesbian folks are folks who are women who are attracted to other women. Gay folks historically have meant men who are attracted to other men, but of course can also be applied to women, right? If we hear of a gay woman, that's a woman who's attracted to other women. Has also been used as a catch-all term. If I say the gay community, usually I am talking about all of those different identities, lesbian, gay, bisexual, all of that in that community. Then we have bisexual. And bisexual, I like to take a second on because it has often been misunderstood. But our current really and our best understanding of bisexual is being attracted to two or more genders. Now, why do I say that? It's because there are folks outside of the gender binary that folks who are bisexual may be attracted to. So for example, I identify as non-binary. There are bisexual people in the world that are attracted to me, and I'm not in that gender binary of woman or man. So oftentimes we've been understanding bisexual to mean I'm attracted to both genders, but gender is so much wider than that, that our understanding of bisexual has to also adjust for that, right? So being attracted to two or more genders. I've also been explained to use it as being attracted to genders that are similar and different from yourself. So the bi coming from that, from same and different. Pansexual is oftentimes associated with bisexuality. And pansexual, all that means is being attracted to like the essence of folks, right? Regardless of how they show up in the world, regardless of maybe their genitalia, regardless of their gender expression, regardless of their legal documentation, being attracted to people, regardless of all those other things. Now, MLM and WLW stand for man-loving man and woman-loving woman. These are two terms that are specific to Black and Brown communities, where Black and Brown queer folks felt like terms like lesbian and gay were very whitewashed. They're often associated with white experiences and didn't really call to some folks within the community as a label that worked for them. And so MLM and WLW were developed in response to that by Black and Brown folks. Now, that's not to say that everybody who is queer and is Black or Brown identifies with these, but these are terms that you may see and are pretty specific to Black and Brown contexts. Now, asexual and aromantic. These two identities really highlight the reasons why we can kind of parse out sexual and romantic orientation, right? So asexual means having little to no sexual attraction to other people, okay? For aromantic, it's having little to no romantic attraction to other people. So you may think of people that you might want to sleep with versus who you want to have an intimate relationship with, the difference between sexual attraction and romantic attraction. For some people, they may experience a lot of romantic attraction, but are not sexually attracted to folks. So they may be asexual. Now, I do like to point out that even if folks are asexual or aromantic, that doesn't mean that they don't participate in sexual acts, right? There may be a number of reasons for folks who are asexual to participate in sexual acts. Perhaps they are engaged in sex work. Perhaps they are involved with a partner who does enjoy sex, and so they want to, make that something as part of their relationship. Perhaps folks are interested in becoming pregnant, right? So there's a lot of reasons why folks who are asexual may participate in sex as well. Aromantic, similarly, there are folks in this world who aren't attracted to folks sexually, but are attracted to folks in a romantic way and want to be romantically intimate with people, but may not be as interested in the sexual piece of relationship. We have straight, meaning heterosexual, right? So men who are attracted to women and women who are attracted to men. And then queer. So queer is another word I like to take just a second on because it has been used as a weapon against LGBT communities throughout history, but it has been reclaimed by LGBT communities, particularly young people who want to say, yes, this word has been used in a negative way, but we're taking the power back, and this is something that we are proud of, right? queer can mean two things. So it can mean both a kind of catch-all term. So if I'm saying the queer community, that includes all of those pieces, right? The LGBTQI community. It can also be a particular identity to folks. So for me, I actually identify as queer. The best way that my boss actually explains it, he says, queer is like telling you that I live in Nashville, but not telling you what street I live on. So you know I'm part of this community, but you don't know what my house looks like. You don't know who's in my home. You don't know who my neighbors are. You don't know what street I'm on, right? You just know that I'm part of this community. And it's a way of signaling to other folks that this is, you know, what I'm part of, but not necessarily pinpointing specifically what that means for folks. Although a lot of folks are willing to do that as well. I like to point out quickly that gender diversity, queerness, and transness have existed in every culture across time in our world, right? There's lots and lots of examples in all sorts of cultures of different experiences with gender. This is not a white thing. This is not an American thing. This is not a 2022 thing. These are identities that have been expressed throughout time and space. Now, of course, there are different places where folks might feel safer to come out. So we might see higher levels of folks who identify as trans at different times in history. But these folks have existed in every culture across time. So I've talked a lot about the gender binary already, and I like to use this model because it helps me to show kind of what we're talking about when we say that the gender binary, that really fun buzzword that is becoming more and more popular, right? So the gender binary meaning, this whole kind of system of understanding that we have that undergirds so much of our world, that basically says if you were assigned male at birth, you're going to grow up and you're going to be a man, you're going to be a very masculine man, and you're going to be attracted to women and only women. Whereas on the converse side, it says that if you're assigned female at birth, you're going to be a woman, you're going to be a very feminine woman, and you're going to be attracted to men and only men, right? This is the gender binary model or the binary gender model. And we're taught this from so many places, right? Education, healthcare, advertisements, the toy aisle at Walmart, right? All of these places give us messages about what is supposed to happen and what comes after whatever it is that you were assigned at birth, right? But in reality, our understanding of gender is much more vast than this. And I say a more inclusive gender model because there's no way I could ever show you a graphic and say, here it is, here's gender. It's just too vast. It is as diverse as humans are, and therefore it's just way more expansive than we could ever show in a graphic. But this is our best shot, right? So here we can see how the more inclusive gender model differs from that binary gender model. Of course, we have a lot more diversity. We have stretches from beyond male and female, man, woman, masculine, feminine, women and men. And we also see how people can move around this graphic. And all movement around this graphic is valid, right? So for me, I was assigned female at birth. I am non-binary. I am androgynous, but can switch my gender expression depending on the time of day and what I'm doing. And my sexual orientation also hops around a bit, but I'm attracted to women for the most part. But every once in a while, there's like really great bass player that just gets me, right? So sometimes our sexual orientation, our gender expression, our gender identities, these things can shift throughout time and space, right? Now that kind of jump across the graphic is just as valid as somebody that does go straight down, right? So for example, my brother is assigned male at birth. He is a man. He's a very masculine young man. And for what I understand, he is attracted to women and only women. Now, even for people like my brother, this gender model, this binary gender model is painful and can be traumatic, right? This binary gender model tells us that, for example, young men can't cry, or that young women can't be CEOs of companies, right? Whereas understanding gender is more vast and as something that can move and something that may change throughout our time and our life, including our gender expression, including our sexual orientation, shows the ways in which those rigid understandings of gender are just incomplete and oftentimes oppressive. to folks who are trans and folks who are not trans. So when we're talking about healthcare, it's important for us to take a moment to think about gender dysphoria versus gender euphoria. So gender dysphoria is a conflict. It's a cognitive dissociation between a person's physical or assigned sex at birth and the gender with which they identify. So people with dysphoria may be uncomfortable with the sex they were assigned at birth. They may be uncomfortable with being described as something in relation to their body or the expected roles of their assigned sex. Folks may be uncomfortable with the ways in which others see them, right? So if I walk into a store and someone calls me ma'am, that may trigger gender dysphoria because that is not how I see myself. It's a cognitive disassociation. And this cognitive dissociation can lead to things like anxiety and depression and lots of other negative health disparities. Whereas on the flip side, we have gender euphoria. And gender euphoria is the happiness upon being correctly gendered, upon naming your identity and being validated and recognized as your authentic self. So for example, if someone uses my pronouns, they, them, theirs, I may experience gender euphoria because it's a happiness upon being correctly gendered. Gender affirmation historically has been called gender transition, but growingly we're trying to move towards this asset-based thinking of gender affirmation. And it's the process by which individuals are affirmed in their gender identity. Trans folks may make a whole different combination of ways in which to affirm their identity. So folks may participate in a social affirmation or social transition, where folks change the clothing they may wear, may use a new set of pronouns, perhaps they are going by a different name. Folks may also participate in medical transition or medical affirmation, doing things like hormone replacement therapy or surgical intervention. And folks may also engage in legal transition or legal affirmation, changing the name and sex on the birth certificate, unless you live in Tennessee, or your driver's license or your passport, etc. So folks go through all sorts of combinations. I, for example, have engaged with social and medical transition, but I'm not interested in a legal transition at all at this point. And there's different reasons for this, right? Folks may not be interested, folks may not have access, right? If you're living in a state where it is difficult to change your name or your birth certificate, if you are uninsured and or your insurance doesn't cover trans-related care, which is very common, you may not have access to our medical interventions. But there's also a lot of people that just choose or are not interested in those things as well. When we're talking about medical affirmation and medical affirming surgery in healthcare, it is medically necessary. It has been shown to decrease dysphoria, so that cognitive dissociation that can lead to depression and anxiety. Not all gender affirming surgery, in fact, most gender affirming surgery is not covered by insurance. Using the correct names and pronouns decreases suicidality in our patients. And trans people who face discrimination from providers and refuse care have higher rates of suicidality. Within the US, we actually have about 10.4 million Americans that identify as LGB, and about 0.6 of US adults or 1.4 million Americans identifying as transgender. So these are actually pretty new numbers. They came out 2 years ago, and also shows us how many young people there are. About 150,000 young people in the United States identify as trans, and that's only 13 to 17-year-olds. We certainly see folks identifying as trans even as young as 2 or 3 years old. But if we look at the maps here on the screen, we can see where the density is. So really on the coast, we see a lot of LGB folks, as well as up in the Northeast and in Florida and our southeasternmost parts of the United States. Similar patterns we see with transgender folks, but actually more of a spread, particularly in the South. We can see there are a number of trans folks living here in high density populations. So thinking about all of these folks in the United States who identify as transgender or LGBTQ, lesbian, gay, bisexual, queer, what are some of the factors that contribute to health disparities for LGBTQI people? Now, this is a really incredible flow chart that the Sylvia Rivera Law Project put together that really is showing the social determinants of health in relation to folks who are LGBTQ, in particular transgender, and really shows the ways in which all of these social determinants can come together to come down on a person, right? So if we think of folks who are experiencing homelessness or at risk for homelessness, if we think of the high levels of, let's say, transgender young people or LGBT young people who are kicked out of the home, about 40% of homeless youth are identifying as LGBT, right? So, and a lot of that is from family rejection. So perhaps they get kicked out of the home. Perhaps they live in a place like Nashville where there's very limited beds for people who are transgender, in particular for young people who are transgender. So even housing, temporary housing, shelters can be inaccessible to trans folks. Perhaps then that might lead them to drop out of school because they don't have access to IDs. They don't have access to things like being able to do your homework. Oftentimes we see students are dropping out of school due to harassment or violence at school. We're seeing higher levels of harassment from students, but also harassment from teachers in schools across the United States in the last 5 years. Of course, there's discrimination in hiring workplace. There are very few laws that actually protect transgender folks. Until the Supreme Court decision a few years ago, there are absolutely no really federal passed laws that said that we cannot discriminate against folks based on gender identity. Of course, there's been various ways that has been interpreted to be protected, but we don't have like a full blanket protections across the country. Of course, we have unequal access to benefits, including especially benefits that require things like ID, when our IDs don't match up, or not aligning with our own identities or our own names or pronouns. And this can also, of course, all contribute to inadequate or no healthcare. Bias and discriminated ignorance in medicine, which we'll talk about. Folks might not have any access to healthcare, specifically trans-related healthcare, LGBTQ-related healthcare, and oftentimes the systemic issues that folks face, including rejection from family, including issues with school, can lead to medical problems with intense mental health issues, as well as other medical physical issues. So this is some data from the LGBTQ people in the US study that the Williams Institute did. And the Williams Institute is an incredible resource for anybody that's looking for data on experiences of LGBTQ folks. Those are actually the same folks that we got the numbers of LGBTQ folks living in the States. But we can see from some of these graphics, the high levels of work, housing, and financial disparities that LGBTQ folks experience. So if we're looking at work and housing barriers, almost 33% of folks who are LGBTQ are unemployed or looking for a job for more than a month within the last year. Almost 40% of folks have been fired or denied a job within their lifetime because of being LGBTQ. Almost a third of folks have been denied a promotion or received a negative evaluation in relation to their identity. And folks have been prevented from moving into or buying a house or apartment from a landlord or realtor within their lifetime. And that is legal a lot of the time, right? In states where there isn't housing protections for LGBTQ folks. Folks are very likely to experience financial crisis in their lives. And really likely more than half of LGBTQ folks experience chronic stress for one reason or another. Some of the larger reasons being jobs leaving you mentally and physically tired, and not being able to make ends meet. So again, I mentioned this statistic a little earlier about LGBTQ youth and homelessness. About 42% of LGBTQ young people say they live in communities that don't accept their identities. This tracks with that really common number. About 40% of young people experiencing homelessness are LGBTQ, which is really wild because only 7% of the youth population in America actually identifies as LGBTQ. So from 7% to 40% is a huge disparity, right? We're seeing just a huge kind of numbers of trans folks and LGBTQ folks being pushed out of their homes, or running away, or experiencing homelessness for a number of reasons. 26% of LGBT young people reported having their families or guardians kicked them out, making them leave their homes as soon as they came out. But almost all service organizations working with homelessness, around homelessness, say they've worked with LGBTQ youth. So this is something that is certainly common across clinical spaces and across service spaces. When we look at LGBTQ youth experiencing homelessness, they often experience higher levels of adversity among their cisgender peers who are also experiencing homelessness. So we see higher levels of being exposed to discrimination or stigma within the family, exposed to stigma or discrimination outside of the family. We see almost threefold folks are exchanging sex for basic needs. Almost 40%, sadly, are forced to have sex. More than half of folks have been physically harmed by others, or it's almost just at half for folks who are non-LGBTQ, and again, have higher levels of things like self-harm. Gender minorities are more likely also to experience unsheltered homelessness, excuse me. So while about 48% of folks experiencing homelessness are unsheltered, for transgender adults, we see that a little bit higher, 56%. And for non-binary adults, yeah, incredibly high, 82% folks. So again, those folks who identify with a gender identity that's different from their sex assigned at birth, but that don't identify within the man or woman binary, are experiencing incredibly high levels of unsheltered homelessness. Minority stress is one reason that we can think through of why folks may be experiencing such incredible disparities. So the minority stress model was actually developed in order to talk about why African American men were experiencing high levels of hypertension, higher levels than other populations. And the minority stress theory posits that it's multi-level experiences of systemic marginalization that minorities experience that contribute to poorer health outcomes. So interpersonal, what's going on in your head, what's going on in your body; interpersonal, what's happening between me and another person; and systemic, what's happening between me and a system. So I may, for example, experience PTSD from some kind of terrible violence that I experienced, right? That is an interpersonal issue. If I walk into a clinic and a receptionist uses the wrong name for me or the wrong pronouns, that's an interpersonal contribution. And then I perhaps am trying to get a surgery covered and insurance is not covering it. That is a systemic marginalization, right? And all of these things come together and push down on minorities and their healthcare. So again, interpersonal factors, what's going on in our head. This oftentimes within LGBT populations looks like internalized sexual or gender prejudice, oftentimes called internalized homophobia or internalized transphobia. So regardless of who you are, you can learn really negative messages about LGBTQ folks, right? If you are growing up and even if you identify as trans from a young age, especially if you're around my age, we have more representation today, but the only representation that I knew of was dead sex workers of trans people on Law and Order. Like truly, that was the only kind of experience of representation that I had growing up. So if I'm seeing those kind of messages on the TV, I might start internalizing some of those ideas, right? About like the justification of violence against trans folks, for example. So these learned negative beliefs, stereotypes, stigmas are held by LGBTQ folks against themselves or maybe against other people within the community. So sometimes we see kind of like inter-community or intra-community policing that happens. And oftentimes people are not fully conscious of this conflict. I see this often when I'm working with young people who perhaps are bullying other young people about them being gay or trans, oftentimes when I'm working with those young people long term, they were actually struggling with something themselves, right? And we're really trying to work it out, and we're not fully conscious of this internalized sexual and gender prejudice. Trans folks are incredibly at risk for violence in lots of different ways in our country. Trans teens with restricted bathroom access. So if we're thinking about schools, right, this would be those teenagers that are forced to use bathrooms that don't align with their gender identity are actually at a higher risk for sexual assault than their cisgender peers. Almost actually more than a third of teens that have been forced to use bathrooms that don't align with their gender identity have been sexually assaulted within those bathrooms, which is a very different narrative than we hear around kind of bathroom protection policies where we're trying to protect cisgender folks. It's actually transgender folks that experience like high levels of violence within bathrooms. Trans folks are more than 4 times as likely to experience violent victimization than cisgender people. Almost half of trans folks have experienced a sexual assault. This number jumps to 65% for those who have experienced homelessness in their lifetime, and 72% for those who have done sex work. Now, oftentimes the folks who experience these things come together on November 20th for International Transgender Day of Remembrance. And International Transgender Day of Remembrance was developed in the 90s in order to mark the incredible amount of folks that are unfortunately murdered or we lose to transgender-based violence in our world every year. So last year in 2021, we had at least 47 people in the United States who were murdered based on their transness. If we look globally, most people, like 96% of people who are trans and are victims of anti-trans violence, anti-trans murders, are trans feminine folks. So trans women or folks that identify within femininity but don't identify with the male that they were assigned at birth. And also globally, people are by and large migrant workers or migrant people in some way, shape, or form. If we're thinking about how this translates to health concerns for trans folks are currently underserved. They're way more likely to delay care due to fear of discrimination or due to past negative experiences. Oftentimes trans folks, and I will add LGBTQ folks, face challenges in finding friendly and knowledgeable providers. And oftentimes trans folks experience higher rates of depression, anxiety, suicidality, and HIV and AIDS. But I hate to just leave you with a lot of like really terrible and depressing statistics about transness, because trans folks, my trans community is way broader than that and way more resilient than that. And despite the violence and disparities that trans folks face, trans people do draw support from peers, community belonging, spirituality, activism, self-awareness. I would say community is one of the largest ones. And trans people are resilient and determined, right, to receive appropriate healthcare. Will often be really scrappy and crafty when trying to figure out healthcare, housing, and are very perseverant when it comes to housing, employment, or family issues. Unfortunately, statistics and discourse around trans folks often don't talk about this resilience and the resourcefulness of trans folks, but this is something that is an incredible asset to our community. So what do we do? What are some practices that we can put in? What are some language that we can use around trans folks and being affirming to trans folks? So if a trans person comes out to you as a provider in particular, we want to ask questions that are going to actually benefit the patient. They're not about personal curiosity, right? Any question that is clinically relevant are okay questions to ask, right? So things like, is there a name you use that is different from what is on your chart? Is there a gender pronoun that you use that is different from what is on your chart? Oftentimes we might have to build trust and rapport with your patients before asking them personal questions, just like any other patient. But in particular for trans folks are often asked intrusive questions just by strangers and may be wary to answer them, right? So this is a trauma that we need to be aware of when we're working with trans patients, and do our best to ask those questions that are clinically relevant. Google exists for a reason. So if there's those questions about personally intimate details that aren't relevant for the clinical work that you are doing, then we do not ask those questions, right? If you have other questions, we have the internet. I welcome you to reach out to the Program for LGBTQ Health at Vanderbilt, and we will help you to navigate those issues as well, those questions that you have. Some things we want to avoid when we talk to trans folks. I would have never really guessed that you're trans, right? These things may feel like they are being supportive, but oftentimes come out as being negative or undermining people's identity, right? It is not a guessing game whether people are trans or not. We cannot tell by looking at folks who is trans and who is not, right? Oftentimes people may look at me and not understand or not know that I'm trans at all, right? And that's okay. That's kind of the beauty of it. It's not a guessing game that we have to play. You look just like a real man or a real woman. Trans men and trans women are real men and real women. So of course they look like a real man or woman. This is undermining people's identity. And then questions like, or comments like, do you want to know how to pass better? If you want people to treat you as a woman, you should do this. We're going to make you look really feminine if you do this, right? Unsolicited advice is another thing, along with those strange inquiries that can often happen that trans folks are often subjected to. And we want to try and avoid them as much as possible. Just like anybody else, unsolicited advice is unsolicited advice. And especially for trans people who have spent a lot of time thinking about how they present themselves and how they show up in the world, this is not a helpful thing. However, there may be times, and there certainly have been times in my life where trans folks do ask and do solicit that advice, and that's okay. We want to support people how they want to be supported, but assuming that people want advice on how to pass better or how to be treated as a woman or man is not super helpful. I also like to point this out because I actually see this incorrectly in the LGBT community as well as outside of the LGBT community. So oftentimes people will confuse the term transgender or cisgender with transgendered or cisgendered. And this is really understandable, right? If I think about transgender, I'm often thinking about transition. And so I might think of it as a verb. But actually, the term transgender is an adjective, and we want to use it as such. So instead of saying Max is transgendered, we might say Max is transgender, or Max is a transgender person. To say Max is transgendered kind of is the same as saying Max is lesbian. It's just not really the way in which we use that term, right? So we want to use it as an adjective. And when referring to trans patients or trans people, we want to always use the name and pronouns that they use, and we never want to refer to them as a gender that they don't identify with, right? So growingly, I'm seeing these articles or these news stories about trans athletes, for example, that will say things like, this biological man that identifies as a woman, right? Or this transgender woman that was male, right? Or is male. Those things are not appropriate to say. We want to talk about folks as they want to be talked about. So trans women are trans women, or perhaps just women, and trans men are trans men. There's no need in comments like this or in discourse like this to really name their sex assigned at birth or whatever gender they don't identify with, right? In a clinical setting, that might be appropriate, but in general, that's not something that we need to do. These other terms on our right are words that are outdated. So again, I won't read them because honestly, it hurts me a little bit to read them. But some of them, like hermaphrodite, are outdated. So the new term again is intersex. Instead of things like sex reassignment surgery or the surgery, we're moving to gender affirmation surgery. Two terms that are context-specific terms are transsexual and pre-op and post-op. So by and large, when we're talking about trans patients, transgender is the correct term to use, right? Transsexual is kind of an outdated and clinical version of transgender. On some medical on electronic health records, this may be the only thing that shows up. Actually, at one of the clinics that I worked at, that is what was the coding that we were allowed. But when we're using terms today in 2022, transgender is the word that we want to use. Now, there are folks who, particularly in older generations, that do identify as transsexual, and that is okay, right? It is not my job as a clinician that if somebody were to come in and say, I'm a transsexual female, for me to say, no, honey, it's 2022, you're a transgender woman, right? We want to mirror the language that people give to us. These identities are important to different people, dependent on generation, dependent on their culture. But we never want to come out the gate using transsexual unless that is something that a patient has used with us first. Similarly, pre-op and post-op are clinically specific terms. So we never want to just in passing, like talking about a trans person, say, that's a post-op trans man. But if we're talking about like perioperative or clinical support for a trans person, that it is important for us to know how many dates, for example, post-op they are, that is okay, right? Saying a patient is 5 days post-op when they're coming for a follow-up, for example, is an important marker. It's a less important marker when we're just talking about trans folks out in the world. Pronouns are incredibly important to healthcare. And when I tell you how important for even one healthcare worker to use people's correct pronouns, it can decrease suicidality dramatically. When we don't use the right pronouns in healthcare settings, patients are unlikely not only to come back to you, but not to come back to any healthcare, right? They're more likely to delay and deny healthcare across the board. And so when we are serving patients who are transgender or serving patients that use pronouns that may be different than what we might assume is incredibly important to do our best to try to implement them. Now at the top, we may be familiar with she, her, hers, and he, him, his. And people are growingly familiar with the pronouns they, them, theirs. Again, those are the pronouns that I use and are, again, growingly popular. So in Gen Z, for example, 80% of those in Gen Z either know somebody that uses they, them, theirs pronouns, or they themselves use they, them, theirs pronouns. 80% of Gen Z knows somebody personally that uses they, them, theirs pronouns, right? So this is something that's certainly growing and something we have to pay more attention to. They, them, theirs pronouns are used similarly to how you would use them for a group. The verb always needs to match. So if we were going to talk about me going to the zoo, you would say, Sean is going to the zoo where they are going to see the monkeys and they're going to buy some cotton candy for their niece. And then they and their niece are going to go ride a horse, for example, right? At all times, that verb is matching the pronoun they, so they are. This can oftentimes feel really intimidating, but something that has been really helpful for me is to remember the times in which we have all, for the most part, probably today, done this in the correct way, used they, them, theirs as a singular pronoun. So for example, when I was a teacher and a student left their backpack in my room, I could turn to my co-teacher and say, somebody left their backpack here. I hope they didn't leave their homework and I hope they have it for the weekend and that they can pick up their backpack on Monday, right? There's no question about if there was multiple people that left their backpack, who this group of people is that left the backpack, right? It's understood that it's a singular person. And this is something that we've all done at one point in our life or other. And it's really helpful for me to think back to those times in which I have done this correctly. Like my body does know how to use these pronouns. It's just about practice. When I first came out as using they, them, theirs, my best friend would talk to her cat every day about what I did using my new pronouns just to practice. So finding a cat or a friend or a coworker to practice using they, them, theirs pronouns can be really helpful. On the bottom, we see this last, I also, want to add that they, them, theirs is in the canon. It is in the Merriam-Webster dictionary as an appropriate term. And if you look in history, oftentimes I get from literacy teachers that this is not correct grammar. William Shakespeare used singular they, Jane Austen used singular they, George Bush in his presidential speech in the 90s used the singular they. Like everybody uses the singular they and has often in the history of time. Again, this like bottom set of pronouns, these, yours, yours, is considered neopronouns. And all that means is folks are using pronouns that are not considered canon yet. So you would use these pronouns like Z is going to the store to pick up ice cream for Zier's girlfriend, and then Z is going to go home to Zier's house. Can be tricky. This is, again, a neo pronouns. I work in a trans health clinic, and I know probably 12 to 15 people that use these pronouns out of the thousands of patients that we see. So certainly not super popular, but it's definitely growing in popularity from the 10 years that I've been doing this work. If you're unsure of someone's pronouns, it's okay to ask. We want to introduce ourselves. It can be the easiest way for us to ask someone else's pronouns. So I can say, hi, my name is Sean. I am a program coordinator. My pronouns are they, them, theirs. What about you? You can wear a pronoun button. They're easily findable online. A lot of healthcare clinics that I work with even have them out for their patients to use if that feels good. Wearing a button with your pronouns can help make others feel comfortable with sharing their pronouns. And oftentimes people get nervous about asking pronouns. They think that it could be transphobic or can somehow upset trans folks. But most trans folks, 99% of trans folks, would appreciate instead folks being asked, right? What pronouns do you use is not a dirty question. That is something that is appreciated by trans folks. And again, sometimes people can get caught in this, but just asking and introducing yourself, I think has shown to be the best way to introduce yourself, particularly if you don't know if a patient might get angry if you ask if you ask their pronouns, right? That is an issue that we might have in some of our clinics at Vanderbilt, depending on the populations that we're working with. By just offering it yourselves, you're opening up the conversation rather than necessarily having to ask, like, what are your pronouns? Sometimes that feels better or like a good first step for folks in a clinical space. If you make a mistake, I promise you, you will. I work with trans people all day, every day. I'm trans myself. I make mistakes, right? I make mistakes with pronouns with people who aren't even trans. That's okay. The best thing that we can do is quickly apologize, quickly change our mistake, and keep it rolling, right? Sean went to the store and they picked up bread. Done. If you apologize and you keep it rolling, you're not putting too much energy into this like traumatic thing that just happened, right? So it has happened to me where I am in a classroom and a teacher uses the wrong pronouns for me. And all of a sudden it's, oh my gosh, Sean, I'm so sorry. I've been working on it. You know, I'm an ally. I went to this training last week, and they go on and on and on and on. And all of a sudden I'm in a position where I have to console my teacher who just used language that was inappropriate for me, right? So we don't want to put trans people in that situation where they're consoling you. And we don't want to put any more trauma into this experience that they're having. So just apologizing or correcting yourself and keeping it moving is the best thing that we can do. So specifically, what can we do around supporting patients in our clinical spaces? Remembering that supporting patients and accessing healthcare is a huge deal. There may be a lot of excitement. We want to be excited for patients, but not over the top. I would say match the energy of our patients as much as possible. But getting it right is a big deal, right? In particular, I can tell you that trans people talk. They know what clinics to go to. They know what doctors can be supportive and not supportive. And word gets out around these things. And so getting this right is a big deal for our individual patients as well as for the larger community. When we're thinking about body part terminology, for examinations, for example, patients' preferences will differ. So folks might have different words that they use for their body that's different in the exam room versus a therapist's office versus in the bedroom, right? They may offer or be interested in using language that might not be what we're used to. So for example, I had top surgery, which was the surgical removal of my breasts. Before I had that done, I really hate calling it my breasts, right? So I would often say my chest and avoid as much as possible using breasts. Asking our patients what words they prefer to use for their body can help us to avoid traumatizing them by using language that might trigger that dysphoria, right? That dissociation between body and person, or person and world. Using the terms that they give us and the language that they give us is a way of practicing trauma-informed care. When a medical exam is necessary, knowing that the patient may experience heightened anxiety or discomfort may trigger dysphoria. I ask that providers explain the exam beforehand, explain why the exam is needed. So for many patients, they may not understand why they have to do a particular procedure if they're part of the LGBTQIA community, right? So maybe providing education as to why cisgender women who have sex with cisgender women still need to get pap tests, even though in a lot of my communities, that is not an understanding that is had. Many trans patients, many LGBTQ patients have been treated as a spectacle and may have trauma around that. So working hard to not do that, right? Also giving folks multiple ways to revoke consent when they're doing an exam. So perhaps there is a word that they can say, as well as a button they can push, as well as a hand signal they can make in case for some reason one of those communication strategies will not work for them. Sometimes our systems that we work with demand that we ask for and document sex and other identities in a very particular way. For example, documents that are often used to report to Title IX may ask for legal sex with only male or female options, right? So if I'm doing a grant, for some reason I have to report to Title IX. Title IX only is asking about female or male. I then have to ask my patients that question, right? Adding an inclusivity statement can show clients that your practice is supportive, even if you have to ask those questions. So this has been like, honestly, a golden trick that we've used in so many of our clinical spaces. We're just saying it, being honest about the culture of power, as Lisa Delpit would say, can really just show that you understand that there are like systemic barriers to things as simple as documenting your gender. So something like we ask your legal sex in order to meet the reporting demands of Title IX. We at the UCC know that gender is a spectrum that goes beyond the binary of female or male. A simple sentence can help make that question less traumatizing for trans folks. When you're forced to chart something or write a letter that does not exactly align with the patient's identity, explaining why you must do so is also important. So for example, I identify as non-binary, I got a top surgery, and the physician that wrote a letter of support for me, at the time there wasn't any codes to support non-binary folks getting top surgery. And so in this letter, in order for it to get covered by insurance, my provider wrote that I was a trans man, even though that is not how I identified. But by sitting with me and saying, we're going to write this letter together and use the language that feels as good as possible while still getting this covered by insurance, changed the way that I saw that, right? And especially with, we see the 21st Century Cares Act, where folks are able to see all of the notes that we're writing in their case notes. It's really important for us to explain why we're doing the things that we're doing, which brings us to charting. Looking to see if your electronic health records has a place to document chosen or preferred name, pronouns, gender identity, legal sex and sex assigned at birth, and document that stuff. This information may show up differently depending on the person's role or view of the chart. But ask the patient how they want this information to be charted, right? So some patients may want you to chart their gender identity as transsexual. Some folks may open up their electronic health records and see that transsexual is on their record. That happened to me, and just be flabbergasted and traumatized by it, honestly. But especially knowing that our patients more and more can see what we are writing in our case notes, and beyond that, from an ethical standard and a trauma-informed standard, we need to be transparent about the ways in which we're writing about patients and be cooperative with them and collaborative with them in writing those charts. Non-binary folks are folks that often have to take on binary identities. So like I said, that physician had to write a letter that said I was a trans man in order for me to access care. Folks often experience discrimination from both outside of and within the trans community. So there are some folks within my community that don't believe that non-binariness is a thing. Healthcare providers and other allies may assume using overly gendered language is affirming. The best thing to do is ask. When I went to get top surgery, my surgeon kept talking about how masculine I was going to look, how I was going to be a man, how like I couldn't wait to make me look really manly and ready to play sports. And like that was not, I mean, I do want to play sports, but none of that was actually of interest to me. I didn't want my chest to look masculine, but in trying to be supportive, my provider missed the mark. So using the language again that our patients give to us, and asking what feels good for them when we're talking about their bodies. So kind of last tricks before we can ask a few questions. We want to create a welcoming practice. Consider the overall experience of LGBTQ patients seeking care. Do you have pride symbols, safe space stickers, LGBTQ themed magazines? If you have televisions, are you watching LGBTQ themed TV shows in the waiting area? Are front office staff trained on how to maintain a safe and welcoming environment? And I would add all staff that are interacting with a patient at all. I can't tell you how many times we have maybe a patient at the hospital that's had a great experience all the way up to the nutrition coordinator coming in and just using the wrong pronouns, or a custodial staff walking in and using the wrong pronouns for somebody. Not in a way to be rude, but it did create some kind of trauma for that patient, right? So thinking about how can every single person that might interact with this patient be trained. Knowing where gender inclusive bathrooms are for trans patients as well. Paperwork sets the tone for an encounter. Inclusive intake forms may ask, what is your gender, including fill-in options. What sex were you assigned at birth? What is your sexual orientation? Who do you have sex with, right? So having a fill-in answer is really important, particularly around gender and sexuality, as so many orientations and gender identities are emerging, but giving folks options to document this as well. And options to say, I do not want to answer this. We want to make sure we're screening for and documenting housing concerns using the ICD-10 CM codes. There's a really great resource from the National Healthcare for the Homeless Council. I can share it with you all in the chat. That has a number of models that you can look at how to identify housing status, right? If we're asking, are you homeless? That may not cut it. We may need to ask a series of questions that might identify exactly what housing status may be. You may want to add fields to your electronic health records to document this. And again, the ask in code document that I just shared in the chat and is available online is a really good way of looking through kind of the options for how we ask those questions. We want to make sure that we're creating and enforcing non-discrimination and privacy policies that support LGBTQI patients. So the Affordable Care Act, thankfully, Section 1557 prohibits discrimination based on sex, which does include sexual orientation and gender, but creating local policies that reinforce that ACA, training patient providers or healthcare workers or any kind of clinical providers in a space before they're seeing patients, and making sure that folks are on the same page and know what the policies are specifically surrounding discrimination and privacy. We always want to follow the patient example for words to describe their identity and body and sexual orientation. It's okay to ask directly again if it's of clinical importance. So for example, what name would you like me to use when addressing you? What pronouns would you like me to use when speaking about you with other providers? Knowing that every patient may not be out in every space. I have patients who are out in my trans health clinic, but then go and see the ENT doctor down the hall and are not out in that same way. Now, if the doctor went through their medical health records thoroughly enough, they would find that. But I've been asked by patients to use a different pronoun when talking to particular providers. So it's always good to check in. Same thing with family members or friends. In our clinic spaces, that might be the first or maybe some of the only spaces that people are out, or they may be out differently in different places, and asking about that is okay. And routinely asking about pronouns, especially when folks are wading through the waters of trying to figure out how they identify and who they are. Routinely asking about those pronouns and names can be really great because folks may shift while they're trying to figure out what feels best to them. Using informed consent when prescribing hormone replacement therapy or other treatments, by knowing that there are so many barriers for folks experiencing homelessness, folks who are LGBTQI, having multiple healthcare visits or requiring that folks see you a number of times can be a barrier for folks to getting health-saving care, including hormone replacement therapy. You definitely want to discuss strategies for carrying syringes, right? That may bar a patient from shelters if they're seen as a dangerous thing that is a dangerous thing, and honor the capacities of transgender people to autonomously make decisions. Recognizing that there are Black market hormones that may be common, and just doing our best to be trauma informed and supporting the best healthcare decisions that folks can make given the resources and the orientations that they have. When we're talking to LGBTQ folks, we want to recognize that they face elevated risks for most mental health conditions, and screen thoroughly for them, but not assume that everybody has all of these conditions that we talked about today, right? They have an increased risk for certain healthcare disparities, but that doesn't mean every trans person has these healthcare disparities. And if you're interested in trans-specific issues, WPATH, the World Professional Association for Trans Health Standards of Care document, is free at wpath.org, and has global kind of best practices, standards of care for what medical providers should be doing. And the newest version is out now for comments and should be out completely very soon. We're often more comfortable feeling like an expert. Given our diverse communities and all of the specialized medical knowledge, achieving expertise is an ideal, not reality. Even as somebody that works in trans health clinic, even people that work outside of the clinic in trans world and is trans myself, I cannot keep up with every single thing with every single identity. And that's okay. We want to conduct our own research as much as possible, acknowledge the gap. So don't pretend like we know what folks are talking about, like actually asking the questions that are clinically relevant, letting them know that there is a gap in your understanding, perhaps enlisting the patient's experience. What does it mean to you? But not overly relying on that, right? Our trans patients come to us for care, not to educate us. Sometimes that's important and necessary, and we want to follow the lead of our trans patients, but just letting folks know like, hey, this is something that I have a gap in, I'm going to confer with this provider. Does that feel okay to you? Know a list of available medical resources in your area and leverage them. And patients don't expect us to be perfect, but they do expect us to be accountable, right? So if we mess up with somebody's pronouns, it's okay, but we want to correct ourselves and commit to doing better in the future. The bottom line, we want to mirror the language that we hear patients using to describe themselves in all the ways. Asking if we're not sure, make sure your question is polite and with the intent of providing better care. Giving people choices that allow them to practice autonomy is so important for trauma-informed care for LGBTQI people, people experiencing homelessness, and every patient that walks in our doors. Knowing the trans competent clinicians and programs in your area to provide a good referral is always important. And overall, just be welcoming and affirming as much as we know how. And you all will be just fine. Cool. So I can take questions, Kelly, or we can move on to the next few slides first. What feels better?
We can answer a few questions right now. It looks like we have one from Caroline in the chat about how best to educate, offer different perspectives, and encourage people that you have relationships with to move towards a more affirming and accepting perspective. Sure. But also, you know, if you have lived experience or work with people, it's feeling very personal and a touchy topic.
Yeah. So what I will say is oftentimes people feel very caught in an all or nothing kind of attitude towards healthcare or towards being affirming to trans folks, especially when folks are not as far along. Encouraging folks to do the small things is better than having folks being afraid to do nothing at all, right? Having a young person who as an adult that uses their pronouns, just one single adult, can decrease suicidality, depression, and anxiety incrementally, right? Or exponentially, excuse me. And so that little change might be different than knowing exactly how I'm going to chart all of these things in my thing, or I'm going to go to all of these trainings around LGBT identity. So really practicing the small things and recognizing that the little things can add up and get to the larger things is really important. I'm not sure if I missed other parts of the question. Top surgery being transgender. yeah, educating, offering different perspective. A lot of the things that I like to do is just backing your play. So knowing some of the studies, or knowing like why it is that you're saying the thing you're doing. Is it because we all want to get on the same page so that we can give this patient the best care that we want to give them? Is it so we're being patient-centered, right, as much as we possibly can? Like finding ways that you can back your play that are either in alignment with the policies of your clinic or the policies of your workspace, or just your personal ethics, and being prepared to like go back to those things, and recognizing that folks are not going to change every bad behavior or maybe transphobic or homophobic behavior overnight. And the little things are better than nothing. So just supporting folks as they're trying to do their best, I think is the best thing we can do.
We have another question about, in regards to the alphabet LGBTQIA+. Is there a preferred acronym? What's the general consensus? And how do we balance brevity with being inclusive?
Absolutely. So in general, what I'm seeing these days is LGBTQIA+. So that would be lesbian, gay, bisexual, trans, queer, intersex, asexual plus, as far as acronym. More and more in medical spaces, we're seeing sexual and gender minorities, which kind of fits all of those things if we're talking in a clinical perspective, or orientation and gender minorities. But shorthand, that's kind of why I love the term queer, because I can say the queer community and it includes all of those various things, and it is an okay thing to say. Of course, there are going to be patients that do not like the term queer, and we don't want to use that to identify them specifically, but it is an okay term to use, to kind of use as a catch-all for the whole of all of those acronyms, because as more and more identities emerge and become more understood by the mainstream, that alphabet soup is going to get thicker and thicker.
And I am wanting to be cognizant of our time. Feel free to continue typing questions into the chat, and while I go over the next few slides, Sean, maybe you can address some of those if we have time. In the meantime, will you go to the next slide?
Mm-hmm.
So just a reminder that we will have the recording of this awesome presentation available on our website, and I will be sending it out in a follow-up email in case y'all would like to share it with others or incorporate it into onboarding new staff. I'd also like to reemphasize that in so many ways, this presentation is a starting point, which I think is clear given the volume of information that we've covered today. And in that vein, the Council is committed to continuing education learning opportunities around this topic as part of our organizational mission. So the first opportunity we have coming up is a learning collaborative for medical and behavioral health clinicians. We're partnering with the National LGBTQIA+ Health Education Center to provide a highly collaborative and informative learning community that lasts a full year and addresses specifically gender affirming care and its intersection with homelessness. We'll discuss topics like hormone replacement, therapy, surgical referrals, postoperative care, and other clinical topics. We're now accepting applications at the link that I will put in the chat now. Feel free to pass along if you know any clinicians in your organization who might be interested. That link is the link to apply. And it also contains more information on requirements for participating in the program. If you would go to the next slide, Sean, I realize you're multitasking at the moment. The other opportunity I'm really excited to share with y'all is a full day training on gender affirming care at our national conference coming up in May. This training will have both clinical and non-clinical topics, so we strongly encourage multidisciplinary teams from health centers and other organizations to register. Sean is our project manager for this full day training as well, so you know it will be an excellent and energizing experience. And just a fun note that we do have an early bird discount available at the moment that will give you 25% off the full registration fee, and you can register on our website. And I'll also put the registration link for our conference in the chat as well. And then one last slide change, Sean, if you wouldn't mind. That is all that we have for y'all today. I want to extend a sincere thank you to Sean for joining us and being such a skilled guide on this admittedly huge topic. Please follow us on social media to stay up to date for more learning opportunities as they come up. And also just to be a part of our HCH community. We love staying in touch with folks. Is there anything else, Sean, that you'd like to add before we sign off?
No, I thank you all so much for having me today, and I look forward to seeing some of y'all in Seattle later this year.
Awesome. Thank you all for joining us, and I hope y'all have a lovely weekend.